Hello, my name is Shannon Loff, and this is my Innovation Project video proposal, What's That for Veterans? Suicide rates within our military veterans has become an increasing concern due to the amplified incidence of death by suicide and the significant changes identified as war progresses over the years. The underlying causes of suicide are unknown, and the acts are completed for many different reasons. However, suicide within veterans has been linked closely to mental health illnesses. The military has attempted to increase their efforts on supporting and reducing the stigma associated with mental health conditions, as well as improving resources available to our military veterans, but the outcome of their attempts are difficult to evaluate due to the size of the military and the several branches involved. According to the U.S. Department of the Army, between 2005 and 2009, suicide rates almost doubled. The 2016 annual suicide rate among veterans aged 18 to 34 is 45 deaths per 100,000 veterans, the highest of any age group, up from 40.4 in 2015. The suicide rate for veterans was 1.5 times greater than for Americans who never served in the military and equates to about 22 veterans a day taking their own lives. In 2016, within the United States, 14% of all adult suicides were veterans. However, only 8% of the entire country's population has ever served in the military. Over the course of 2015 to 2016, the national suicide rate rose nearly 21%. Among veterans alone, the rate increased 26% within the same time frame. Perhaps the greatest healthcare cost of suicide is the drastic cuts being applied to mental health services and support. From 2009 to 2011, cuts to the mental health, non-Medicaid state spending totaled nearly $1.6 billion, and services were stopped, including community and hospital-based psychiatric care, housing, and access to medication. The stimulus package allowed for a temporary increase in federal funding for Medicaid. However, this funding has ceased, leaving those individuals without the help. Between 2009 and 2011, $1.8 billion was cut cumulatively between all states for mental health illness services. California alone cut $587.4 million, while New York cut $132 million, and Illinois cut $113.7 million. Consequences to these cuts has led to increased emergency room visits, hospitalizations, premature deaths, and suicides, as well as further diminished access. Within rural residential areas, there are only 16 psychologists per 100,000 rural residents, and about half that amount in urban and suburban areas. Within this rural population, approximately 85% live in an area where there is a shortage of mental health professionals, and the providers that do practice feel less knowledgeable regarding PTSD, substance abuse, depression, and suicide treatment, and do not typically ask their patient if they are a veteran. Individuals with mental health illnesses are also cared for by family, friends, and relatives. On average, 32 hours a week are spent on caring for these family members. However, there is no monetary gain from it. The U.S. economy loses $193.2 billion a year in lost earnings due to this. Globally, depression and anxiety alone lead to a loss of $1 trillion in productivity, and depression is the leading cause of disability worldwide. Since the economic crisis started in 2009, the National Association of State Mental Health Program Directors reported nearly 4,000 state psychiatric beds have been eliminated, and 11 state hospitals have been closed, leaving fewer places to refer people in a psychiatric crisis. In 2000, the U.S. economic burden of depression was estimated at $83.1 billion. Of that, $26.1 billion was related directly to medical costs, $5.4 billion related to suicide mortality, and $51.5 billion due to workplace costs. In addition, in 2014, 1 out of every 8 Americans aged 12 and over were currently prescribed or taking antidepressants. Between 1994 and 2014, the cost of antidepressants rose 65%, leading to a greater burden on consumers to purchase their medication required for treatment. Suicide did not become a central issue of concern within the United States until the mid-1990s, when survivors of suicide loss brought attention to the need to the nation to prevent suicide. In 2007, Joshua Omvig Veterans Suicide Prevention Act was written into federal law. The law supports the development of a comprehensive program to reduce the incidence of suicide among veterans. It was written into effect when a veteran of Operation Iraqi Freedom committed suicide in 2005. The Secretary of the U.S. Department of Veteran Affairs realized the need for the comprehensive suicide prevention program for veterans. The law requires staff education, mental health assessments as part of the overall health assessment, a suicide prevention coordinator at each VA medical center, research efforts, 24-hour mental health care, a toll-free crisis line, and outreach to and education for veterans and their families. In 2009, the VA added a chat service line in order to reach veterans who preferred to use the internet for outreach. Suicide rates among military veterans attracted more attention shortly after the Vietnam War. Suicide rates were not noted to be higher than the general public. However, studies identified males who had previously served in the military were known to commit suicide at a younger age compared to the general population. It was also discovered that military veterans living with a mental illness committed suicide 9-fold compared to the general population. With the new conflicts in the Iraqi and Afghanistan wars, increased rates of suicide have been attributed to repeat deployment, longer tours, change in type of warfare, and injuries sustained. Lower mortality risks of earlier veterans were associated with the healthy soldier effect, which was equated to be similar to the healthy worker effect. In the early years of the military, when a soldier separated from active duty, They are believed to be healthier than the general population due to the intense screening required prior to military services and having better access to medical care during and after military. The difference between previous wartime veterans and current is the healthy soldier effect is not rendering the same positive outcomes as it once used to do in relation to risk of suicide. The risk of suicide within current wartime veterans is approximately 41 to 61% higher than the U.S. general population. The U.S. Department of Defense and the Veterans Health Administration have attempted to improve mental health services by expanding screening and treatment for PTSD and depression, as well as striving to reduce the stigma surrounding mental illness. In 2006, BattleMind was launched as a program to help soldiers pre-deployment learn skills for coping with battle and post-deployment to learn how to readjust. Despite all this effort, veterans who do receive help are often given inadequate care, and efforts to enhance and promote high-quality mental health care were recommended by RAND to the Department of Defense and the Veteran Health Administration. Within the last 2 years, efforts by the Department of Veterans Affairs fell off when it came to suicide prevention in our veterans, even though reducing suicide rates is the agency's top clinical priority and millions of dollars budgeted for outreach went unspent. With healthcare reform and controversial medical device taxes, technology companies are striving to implement products that are cheaper, faster, and more efficient to patient care. The mobile application WhatsApp is a free app on iOS and Android devices utilizing cognitive behavioral therapy and acceptance commitment therapy to help individuals cope with depression, anxiety, stress, and more. The purpose of utilizing this specific app would allow for veterans or civilians the ability to have help at hand. There's a positive and negative habit tracker, which can help negate habits that are counterproductive. There's also a Get Grounded page, which provides over 100 different questions, which can help pinpoint what you are feeling. The Thinking Patterns page then teaches you how to stop negative internal monologues. The Catastrophic Scale helps to put one's troubles into perspective. The app was released in March of 2015 and has a user rating of 4.5 out of 5. It has a modern design, simple headings, and easy-to-follow methods. In order for implementation at my facility, I interviewed the chief nursing officer, the nurses, and the quality control director. I chose the CNO because he has the ability to influence the widespread adoption of the mobile app, as well as routinely engages in evidence-based practice defining new and improved methods for treatment. I interviewed the nurses because they have day-to-day interaction with patients and will be doing the teaching of the app. They will also see how this change will affect the patients and if improvement in care is being seen. Lastly, I interviewed the quality control director because he deals with the ethical understanding of the app and its implementation in the workplace. Each interviewee was asked a series of questions so that I was able to identify different perspectives of the problem and how implementation of the application may help. Interviewing the CNO confirmed the need to have additional methods of care for our military population, as there is a growing concern for them not seeking out and accepting psychiatric care. The hospital monitors return rates of our military population, as well as deaths. Data is collected by our assessment referral department and reported during our monthly meetings held for upper management and posted in the nursing lounge. Data from this is taken to trainings, and individuals are re-educated on coping measures to teach and ways to analyze whether a patient is ready for discharge and signs to look for regarding heartbreak true feelings. The CNO believed that a mobile application may help in the internal feelings of depression, anxiety, and post-traumatic stress disorder. He stated it would be vital to introduce the app on day one and help them utilize the app each day to get them used to it. This way, when they leave the hospital, it would already be routine and part of their daily activity. While interviewing the nurses, they felt strongly regarding the military population as well. They felt that current discharge education fell short of what could be accomplished during discharge. They felt it was rushed and that the patient did not pay close enough attention to following discharge instructions. They felt a mobile app would be beneficial, but add to their already high patient loads, tasks they needed to perform, and increase the time it took to complete a discharge. The nurses felt like this should be education performed by the therapist within the facility. I followed this with asking if they felt it would be appropriate to start using the app while still inpatient. To this, they responded they would not have the time to teach the patient, and again, this should be something the therapist did. My final interview was with the quality control director. He felt the addition of the mobile app for treatment would be beneficial, as it would leave the patient with an ability to continue with their treatment and have a resource prior to having their follow-up appointments. The quality control director did not see any ethical concerns regarding the use of the mobile app, as it is individualized and no one has to share their results if it is not wanted. He also felt that the benefits of using an app post-discharge would outweigh the costs and risks of implementation. Suicide is the leading cause of death within the U.S., and the statistics continue to increase. Approximately 22 veterans commit suicide each day, with it approximately 22 times greater than seen within the civilian population. With implementation of a new innovation solution such as the WhatsApp, we can identify and pinpoint individuals that would benefit from this adjunct therapy. Utilizing the app will allow for trends to be seen for each individual utilizing it. It provides alternative behavioral engagements to acts of harming oneself and allows for treatment options right at hand. Thank you for listening to my innovation project.